Next presentation is Giovanni Parmigiani from the Dana-Farber Cancer Institute.
Thank you, Constantine. Am I already 5 minutes and 52 seconds into my talk? So thank you, Constantine, and thank you to the organizers for the privilege of speaking to this audience. It's been a fantastic day so far. I've learned a lot. My favorite slide was one where a doctor was counseling a patient in front of a computer and 2 crystal balls. There was no explicit denomination for which one was the outgoing and the incoming technology. Maybe the verbiage was more clear about that, but I must have spaced out on it. I feel like there's still quite a bit of anxiety over the application of machine learning in medical context. So what I would like to try to do is to put forth a few thoughts about very pragmatically how to find out what works and what doesn't in a more transparent way. Let me start with the disclosure information. The only piece that is even remotely connected to what I'm going to talk about is the patent on Postin for debulking in ovarian cancer, which is not going to be discussed today, but is based on the same data that I will discuss today. So I'm going to take a different perspective from Steve, and I'm going to talk about a classification that is making predictions about a patient feature, either future or a hidden feature or something that we would like to try to predict and we don't know. And I'm going to talk about classification based on lots of data, as typical in genomics, as typical in radiomics, as typical in many of the applications of machine learning to medicine that are now causing so much excitement as well as a little bit of anxiety. I'd like to refer to this picture, and starting with study 1 on the left, we have a response variable, which is what we are trying to predict, say whether the patient will respond to a certain drug or whether there's a hidden condition and so forth. And a whole lot of different predictors, each represented by 1 row in the matrix that is below the response. So often these predictors are used to select a subset that is described as a signature that identifies a particular feature that we're trying to predict. And in general, a classifier is something that I will define as an approximation to the truth when the truth is not available to us based on this signature. So this is the terminology. What I would like to discuss today is to try to understand what are good ways of validating classifiers before they're used clinically and assessing their replicability across different contexts. This is closely related to the result reproducibility that Steve was alluding to, but it's not quite the same concept for 2 reasons. There isn't necessarily an underlying truth that we're after. We're after some useful tool for separating patients into subgroups. I think personally that precision medicine is all about identifying subgroups of patients that can be reliably predicted to behave similarly. So there isn't really a concept of truth. Are we putting likes with likes? And also it's important if we develop tools based on a certain corpus of data that before it's implemented clinically, it is demonstrated to have similar properties in other data sets. And that's something that's very well known to the clinical community, but it will be the foundation of many of the concepts that I will discuss today. So that's the general idea, trying to say something sensible about what are good ways of assessing replication and validation before clinical implementation. I'm going to do that through a case study in ovarian cancer, which we started shortly after the Potty scandal with support from the ARA funding mechanism, which meant that we had a lot of money to spend in a very limited period of time, and that will sort of explain some of the choices that we've made that you will see us make here. The concept here was to try to give a validation, a comprehensive validation of existing predictors or classifiers for ovarian cancer survival, and so we designed this sort of parallel stream validation. You go back on this one, maybe it's this button here. Yeah. There are 2 parallel streams. One is a comprehensive review and reproducibility analysis of all the classifiers that had been published, and that's on the left. And on the right is a comprehensive review and data curation of all the public data sets that would be relevant for the validation of those classifiers. Okay, so at the bottom, I would like to focus on the two outcomes of these. 14 prediction models that have been re-implemented with a sufficient degree of similarity to the original publication that we feel confident about their use, and 14 data sets with a sufficient subset of the predictors that are relevant for us to continue validating on those. It's a long story how we got there, but some of the themes that I was hoping to highlight as part of that have been highlighted today. Mostly the importance of data curation, the importance of phenotypes, and how difficult and expensive it is to get to the point that data are truly homogenized before we can validate machine learning approaches across studies. I want to take a quick detour on the issue of reproducibility, not replicability as I defined it earlier, but reproducibility as Steve was defining in his top category. Can we redo the results if we try? There are 4 categories of that we studied. Whether the actual classifier was provided in the original paper, that's the column on the left, whether the training data were available, whether the validation data were available, and whether we were able to verify the implementation, and we tried very, very hard. As you see, the picture is not that disheartening at all. We were able to find to fill most of those cases with black, and it's only a few situations where we were not able to verify the implementation or find the validation data available. This is a lot more optimistic than similar attempts that had been made in the space of gene expression-based predictors, partly because we had the resources to really go deep into this. So there's no doubt that both replicability and reproducibility are extremely expensive and difficult, and it's a resource-intensive enterprise. And part of the gap is that resources are often diverted elsewhere. So, but back to the issue of replication. You've seen the design for the comprehensive review. At the bottom, we have 14 prediction models or classifiers and 10 data sets. So this chart has 1 row for each of the prediction models and 1 column for each of the data sets. The number in the table is a measure of the association between the score that each classifier predicts and survival using a model that is essentially a Cox proportional hazards model. So you can think about a value in the log scale. So a value of 0 is basically no predictive value, and the higher it is, the more a high score is associated with poor survival. I painted in black the combinations between classifiers and data sets where the classifier was evaluated on the same data set that was used for training it. So that's not an external validation. It's a cross-validation where you set aside some subset of the data of the original study and do that over and over again. And you can see off the bat that numbers in the black boxes are far bigger than the number in the remainder of the table. That's something that is well known, but it's borne out of this more comprehensive analysis as well. And it's one of the important lessons, I think, that the clinical community has been learning often the hard way over the past few years in attempting to translate these machine learning methodologies into clinical applications. We've also taken a further step, and we actually highlighted in gray the rectangles that refer to situations where the original paper published a validation as part of the original publication, and that data set was included. And the reason why we thought that might be interesting is that we suspected that there may be a bias in the selection of which data sets are used as validation data set in reaching a publication. Sometimes that bias could simply be unintentional. If you don't have the lucky data sets, then you don't have a validated algorithm and you don't get the paper published. So it's not necessarily malice on the investigator standpoint part, but there is a little bit of that bias playing, and we can delve into the results a little bit further in the Q&A if you'd like me to take a look at that. Also, there are very strong study effects. The studies on the left are easier to validate on, and that part of the reason, particularly for the Dressman study, is the confounding between batch effects and the severity of disease. A batch effect is a laboratory artifact that in this case affected a large number of genes. So for a predictor, it would be easy to find in this set genes to include in the signature and the subsequent classifier that were there that were effective just as a result of the confounding in the original data set. So that's a big picture. I think that this context can be useful for going to the next step and saying we have all these algorithms, which one should we trust, which one should we implement? Again, I don't think as this is a question of truth and falsity, I like to paraphrase maybe the most famous motto in statistics, which is that all models are wrong, but some are useful. In this case, all classifiers are wrong, but some are more useful than others. And a meta-analytic approach on the rows would give you the ability to come up with a forest plot on the right where you can rank the classifier by their prediction ability, and then push all the decisions about adoption and which context and for which patient to a serious decision analysis that is contextualized to the clinical environment and maybe even to the patient's own preferences. Okay, so yeah, good. So a couple of taking off points from here. This is a little bit more technical in nature, but it has to do with trying to understand why these studies are different and why it is that if we try to learn about the performance of a classifier in the same study where we trained it, we don't get as realistic a picture of its prediction ability as we do when we try to move it outside and generalize it. And so to this extent, this compares two types of measure: cross-validation measures that are internal to a data set to cross-study validation, which jump off to an external data set. Let's focus on the white and the gray. The white is the cross-study validation, and the gray is the cross-validation. There are two sets because we look at both gene expression and RNA-seq to demonstrate that even with newer technology, these trade-offs have not changed one bit. And then what we did is, using resampling techniques on the real data, we analyzed what happens if we could make all the studies the same in terms of the composition of relevant clinical covariates. Does that gap go away? It reduces some, but it doesn't go away. What happens if we filter only to the genes that, by some measure that we can discuss offline, are more reliably measured and they're strong in terms of the signal that is coming from these platforms? Again, things get closer, but things don't go away. What if we equalize the overall severity of the patients that are included in the mix by making the baseline hazards the same? Again, things don't go away completely, and it's only when you make the coefficients that talk about the relationship between the genotype or the expression and the phenotype in this case that we can wipe out the whole effect. And there are many possible explanations for this. One is that there is really a different genetic mix of biological mechanisms in the population, and another is that there is enough confounding between these genes and some of the factors that are not measured, and that confounding is different from study to study in ways that is not completely accounted for when we try all these other things. The bottom line is that if you are training a classifier using whatever machine learning technique you would like, the ability of that classifier to do well on a set-aside piece of the original data set is going to be way too optimistic in predicting what's going to happen when you take it elsewhere. And that's something that is I think, now very well established. So from a more methodological standpoint, I think that this has important implications for how we choose how to develop these classifiers, because cross-validation and cross-study validation rank different classifiers very differently. And the simplest classifiers often do a lot better at cross-study validation, while the more complex ones do better at cross-validation. And here, one that does particularly well is this plus-minus approach, which essentially is a neural network with one neuron, if you can think about it that way, because it's just an average of the good prognosis and bad prognosis gene. So with that in mind, I'm interested in laying the foundations for trying to develop machine learning approaches that do well when they are ported from a data set to another. And I think that one venue for building such classifiers is to move beyond the single data set training idea and look at an ensemble or a bit of a mini meta-analysis for your training set. My hope is that if you teach your classifiers on multiple data sets, they will not only learn about what predicts patients' outcome, but we will also learn about how that will vary from one context to another, and will only retain the features that are more stable across these multiple studies. So one of the approaches that we have for doing this is based on the concept of ensemble learning, which is just simply, instead of believing one model, you come up with a reasonable collection and average them or take a voting of all these various models. And the way we construct these ensembles is by taking studies and by taking multiple types of different classifiers and then applying each classifier to each study. And this gives you a collection where each classifier is being trained with one approach on one model. And then we worry about how to combine them with some weights. Sometimes these weights are just simple averages. Sometimes they're determined optimally using approaches that we are doing the math for. So this idea, I think, has shown quite a bit of promise. And I want to bring it back to these ovarian cancer data sets to show what happens. And I want to start as the baseline with what happens if you take, this is an analysis based on what we call leave one study out validation. If you have 10 studies, or in our earlier example 14, you leave one out, you train on 13 and see how that does, and then you repeat that exercise with each study left out in turn. So one thing that you can do when you are training on the 13 out of the 14 is to put them all together in some integrated way, throw a big machine learning approach at that one merge study and see how that does. So that's approach one. Approach two is a meta-analytic approach where the machine learning methodology is based on low-dimensional coefficients, like a regression has coefficients. And you can do a meta-analysis of those across studies, and then use the meta-analyzed coefficient as the input for the combined model. So those are the two approaches in yellow. Then the two on the right are these two ensemble approaches, one with a simple equal weight for each of the elements of the ensemble, and on the right with weights that are thought through a little bit more carefully. And you can see that our measure of discrimination is increased significantly when you move to this new approach. So there is evidence that there is some learning about this intrinsic robustness in going from the training set to the validation set by using this approach. So some thoughts to wrap this discussion up. My perspective is that the ability to take classifiers trained in one context and take them to different contexts, whether they be studies, whether they be portions of these large consortia, whether it be different genetic population, whether it be future data, this is an essential part of the translational process that goes from the machine learning to bedside. In this, it's not completely productive to think about this validation step as a 0-1 process. And I think it's more useful to think about the fact that there's always going to be some variation across studies. Some of it is driven by the characteristics of the patients. Some is driven by the characteristics of the data collection. Some is driven by the characteristics of the biological assays and so forth. And so understanding this variability is important for this trajectory. And it often contributes a real genuine scientific insight as well. So it's something that we shouldn't shy away from, something that we should model and understand and document to the extent possible. So if you buy that perspective, then I think that there can be progress in replicability along at least 3 bullet points that I've highlighted. One is education of the scientific community about how much cross-validation, cross-study validation, variation to expect. And we have done classifiers in enough context that we can do a little bit of science of data science and try to understand what are the likely gaps when you jump off, and so that we can predict a little bit better the applicability of an algorithm to a clinical situation. The second is that we need to work harder, I think, at generating these curated, comprehensive data collection. We've seen many really interesting presentations earlier today about these topics. These are fundamental in bringing the machine learning community and the clinical community closer so that they both talk the same language and that the machine learning people can validate tools on really relevant data. And finally, and that's what was my one slide about multi-study machine learning, I think that machine learning itself needs an upgrade in terms of thinking about these complex collection of data, because healthcare is very, very far from the sort of game of Go situation where you can throw massive amounts of data at very deep learners and be done just by sheer data side, where we're still going to have to deal with relative small sample size. So with that,
thank you very much.
You're welcome.
Thank you.